Hi everyone, my name is Sahdev Baweja. I'm one of the side members here at your medical college, and today I have the pleasure of interviewing Dr. Schwartz. He's a neurologist and neuro-ophthalmologist at Westchester Medical Center. Dr. Schwartz, thank you so much for joining us today.
Thanks for having me.
So Dr. Schwartz, to start us off, could you talk about why you chose neurology and then more specifically neuro-ophthalmology as a field?
Um, that's a great question. Well, I think neurology, well, I guess when I was doing my clinical clerkships and basic sciences, I was always interested in the neurosciences and the brain in particular. And as I moved into my clerkship year, I was drawn to internal medicine and neurology in particular. Um, I I mean, it's a very long story, but the neurology I think is a great field in that you get to really think broadly about patients, um, and we spend a lot more time with patients, really trying to hone in on the specifics of the history, what's bringing the patient to care, and then doing a really detailed exam and assessment to just sort of drive the care of the patient, and it really draws a lot on. I mean, the classical neurology draws a lot on anatomic localization of symptoms. That's like the classic kind of teaching of neurology, how it began in the 1800s and 1900s. Um, and nowadays, and a lot of that was done like on autopsies and things. But nowadays, like, we have so many amazing tools to really study um, and localize, where things are going on in the nervous system. Like, MRI, for instance, obviously is a very powerful tool. But in my field, in neuro-ophthalmology, we use uh, optical coherence tomography, which is a form of infrared light, that we use to study the retina and the optic nerves. So, we can really understand. So, neuro-ophthalmology is kind of a subfield within neurology and ophthalmology. We have neurologists and ophthalmologists who go into neuro-ophthalmology. Um, we're really more of a diagnostic or consultative kind of field. Like, we don't do procedures or surgeries, but we use the tools of MRI, OCT, but also the kind of listening to the patient and taking a detailed history. All of that still applies. But we have a lot of we have a long kind of assessment, and the appointments tend to be a little bit more detailed and longer. That's because we're doing a lot more testing and assessment of patients' kind of visual function, um, using tools like OCT and visual field, where we're like actually trying to like identify like where specifically patients are having trouble with their vision. So, like, for instance, like this morning I was reviewing a patient. So we deal with a lot of patients who have um, either medical or surgical problems that affect the visual pathway. So, the patient I was reviewing this morning, she had a large pituitary tumor that was kind of extending into the cavernous sinus and basically causing like cranial neuropathy. So she had like a third nerve palsy, and she also had a fifth nerve palsy and trigeminal neuralgia and trigeminal corneal anesthesia. So that can basically, when you have like reduced sort of sensitivity of the cornea from a nerve, from a process that's infringing on the trigeminal nerve, patients have a lot of pain, they have photophobia, and they have a lot of corneal sensitivity, and they can have reduced vision as a result of that. So we're using this very detailed assessment of the vision, to understand what's going on, and when to intervene, which is not always a clear, without that information, it can be a little bit murky about when to intervene. So that's how we can help kind of augment the care that's going on, and we're a very interdisciplinary field, neuro-ophthalmology. We're working very closely. This is a patient I share with like a neurosurgeon here who does skull-based neurosurgery. But I also work with a lot of patients with MS or with other kind of endocrine issues or rheumatologic issues. So we work very collaboratively in a team to understand what's going on with the patient, specifically how some kind of underlying medical or neurological process is affecting their vision, and we can use that to kind of help direct the care of the patient. So from the most invasive, kind of intense therapies like brain surgery or radiation, that would be one end of the spectrum, to other types of therapies like steroids for MS or optic neuritis, things like that. So
Okay.
it's a really cool field. I was it can be a little daunting as a neurologist to go into something that's so ophthalmic. But yeah, I think you just kind of learn things over time, just like as you approach any other kind of new thing. It just takes time to expand your knowledge base, and you just accumulate new information over time.
What's the training process like to become a neurologist? I'm guessing it's a fellowship after neurology.
Yeah, so for neuro-ophthalmology, it's a 1 year fellowship after neurology training or ophthalmology training.
Okay.
Yeah.
And you sort of touched on this earlier, but what are the common conditions you say you would treat?
So, I mean, that's a little bit of a tough question to answer because we treat a lot of different things. But just to name some conditions that you might be familiar with, but like we treat patients with myasthenia gravis, affecting the visual pathway or the efferent visual pathway. Um, so myasthenia, multiple sclerosis, idiopathic intracranial hypertension. We see a lot of patients with like different brain tumors that affect the visual pathways. Um, we see people with rheumatologic conditions that affect vision, like giant cell arteritis. Um, those would be kind of some of the maybe the more like common issues that we see. I'd say, of those things, probably intracranial hypertension is one of the more common things that we deal with in the clinic. That would be the one thing that we're really like the primary. That especially IAH is like the one thing that neuro-ophthalmologists really kind of own. And a lot of the other conditions are, we're working together with other fields to try to figure out what's going on.
Okay. So could you kind of describe what a day or a week in your life is like?
So, I was hired here pretty recently. I just started working at Westchester Medical Center. So, um, I was hired to do both, neuro-ophthalmology and general neurology, and I do both. I do about approximately 1 day a week of neuro-ophthalmology clinic, which is like an outpatient clinic. So, when I'm there, I'm basically there for the day. I usually see between 8 and 10 patients in the day. Um, the patients come in, they're seen in an ophthalmology setting. So they're seen by an ophthalmic technician who checks their vision, checks a few other aspects of their vision, like their pupils or their color vision. And then we'll do some more testing with the patient before I see them. So before I see the patient, they've done like a visual field test, which is like this kind of like this video game where you sit in a fishbowl and they shine lights in your peripheral vision and you're clicking to see how sensitive your peripheral vision is. So we'll do a visual field, OCT. We'll dilate the patient and take pictures of the fundus. So the visits tend to be pretty long. Like patients are generally in the office between 2 and 3 hours. Um, but by the time I've seen them, they've gotten most of their work up, and I've reviewed their chart. So that's kind of like my neuro-ophthalmology day. My general neurology day, I was actually um, I work in Kingston in the Catskills. So that's like more of a rural kind of clinical setting, and I see patients there for the entire day. Usually like around 8 patients, um, a few new patients, a few follow-up patients, and there I'm just acting kind of as like a general neurologist. So I see people with all kinds of stuff like chronic pain and migraine and epilepsy. Um, and occasionally I see some patients with like neuro-ophthalmic issues. So that's kind of what I do up there. And then I have I do a few weeks on inpatient service here in Valhalla. So I'm a consult attending here. I'm doing a few weeks of the neurohospitalist service, like the inpatient neurohospitalist service. I also work with the ophthalmology residents. Like this week, I'm on call for neuro-ophthalmology. So if there are neuro-ophthalmology consults in the hospital, then I'll see them with the neuro-ophthalmology residents. So yeah, it's kind of a mixed bag. I do like a lot of different things, and my schedule is a little bit funky, but I like it, and it makes it. I mean, never there's never like a day where I'm just seeing like one of a particular thing all day. So it's every patient is kind of completely different, and they're completely different issues. So it makes it interesting. I mean, it's definitely it's fun and stimulating to be in a place like this, especially an academic environment where I have colleagues who are a little bit more specialized than I am in other things. I can ask about what's going on with dementia or what's going on with epilepsy. There are all the specialists we have here. It's nice to have those resources. I think if I were by myself or in like a private practice environment, I maybe would be a little bit bored. but but yeah, it's never there's never a dull moment. So so far so good.
That's good. Could you describe some changes that have either happened recently in your field or you foresee happening in the future?
Sure. That's a great question. I have to think about that. Well, I mean, the last 10 years, neuro-ophthalmology has been really transformed by OCT. So OCT is great. It's like a non-invasive way to really, the optic nerve is really it's part of the brain. It's an extension of the brain. So we can really get like these incredible pictures of the optic nerves, and the algorithms that we use are designed to take these like super detailed measurements of the different segments of the optic nerve so we can understand what's going on. Like for instance, in like multiple sclerosis or patients who have maybe early symptoms of MS, or they're like their diagnosis is a little bit hazy. Some patients actually have changes on OCT, so we can use OCT to detect um, changes to the optic nerve that might be happening that the patient isn't really aware of. So actually, a few months ago, this large international society of scientists and MS clinicians. So they have this McDonald criteria, which is you might know from your clerkships that the MS has always historically been kind of a clinical diagnosis, and we rely on sort of relapses that are separated in time and space. So time meaning like you had a lesion affect one part of the nervous system at one point in time, and then at another point in time, you had another episode or another event that attacked another part of the nervous system. But we also require to make a diagnosis of MS, you also have to have different areas of the different regions of the nervous system that are impacted. So a lot of patients, get MRIs, for instance, and they find MS lesions, and the patient doesn't even know they have MS, or they have one event and nothing else, on exam or on the MRI. So it's a little unclear, like, are they going to develop MS? Like, there's a very strong chance of it happening. Like if you have optic neuritis, your risk of developing MS in the future, if you don't have MRI lesions, is like 25%. If you do have MRI lesions, the risk is even higher. So with OCT, now that it's actually part of the criteria for MS. So if a patient comes to care and they get an OCT as part of their evaluation, part of their neurologic evaluation, and it shows actual thinning of the optic nerve tissue, then we can make a diagnosis sooner, and that patient could potentially be started on treatment earlier and we know that the sooner patients are on treatment, the better the outcomes generally tend to be. So that's like a big change in the last. Well, the MS criteria like just happened like a couple of months ago. OCT has been in play in ophthalmology for a long time, for probably like the last 10 or 20 years, but it's now it's very refined, and we know how to use it well, and I think like there are some technical problems, but those tend to be less of an issue. So we can use OCT really to kind of capture things that are going on that the patient may not even be aware of. So that's really nice. That's a really nice tool to be able to have and to be able to understand and use it in the right context. It can be super powerful.
And any changes you see forthcoming in the field in the next 15, 20 years?
Um, well, neuro-ophthalmology is kind of a small field. So, we have maybe a couple of hundred, neuro-ophthalmologists in the country that are trained. Neuro-ophthalmology fellowships are always underfilled. There's always spaces for new people interested in neuro-ophthalmology. So it's a big field. But that as a result, it means that, um, unlike say like cardiology or something, a field where there's a lot more people with heart conditions and a lot more cardiologists out there, they can take hundreds of thousands of patients, and they can randomize those patients to some type of medicine for cholesterol or something like that. They can do much more powerful studies statistically and with kind of rigor. Neuro-ophthalmologists are a little bit more limited because there are just fewer people with those problems, and there are fewer neuro-ophthalmologists. So we're starting to pool our data together. We're starting to kind of coordinate and put our resources together. So for instance, like we now have seen an association with these new medications for weight loss. Like Wegovy and those types of things that you see on a lot of patients are on nowadays. But those have been shown to have possibly an association with ischemic optic neuropathy, which can be really devastating visual condition. But we only know it from like retrospective data. So the first paper was published last year. It showed like a very small association with, and in our practice here at Westchester, we've had a couple patients on Wegovy who developed ischemic optic neuropathy and have really reduced vision. So, but we don't know if it's causal because it's just an association, and that correlation doesn't equal causation. You have to show kind of a temporal relationship. So, I think there are a lot of people who are interested in this. The drugs are really becoming very widespread. And ease of access is greater and greater. So, but now that we have kind of the infrastructure in place, we can pool together, and we're working on an IRB here to try to like study this issue in a little bit more rigor. So that's like one area. I guess that's not like a specific thing per se, but it's a change in the field, I think, and the mentality of how we go about asking questions and doing research and discovering new data that influence, the decisions that you make. It's complicated. Like, I've had a couple patients on Wegovy, come in with vision loss, and it's not there's not a clear answer. It's not like, you can just tell the patient this causes ischemic optic neuropathy, you should stop. There's a small association. It may be related to your vision loss, but we don't exactly know. But maybe you should consider stopping it. So that's a harder, it's a much more complicated, nuanced thing, to try to explain. So, but the more data we have, the more, sort of the better the answer that we can give to patients, the more informed decision people can make about these drugs and whether what impact they might have.
Okay. And what challenges, or what's the biggest challenge you think neurologists and neuro-ophthalmologists face?
Uh, well, well, the patients can be kind of complicated. They can have multiple issues going on. Um, and it can take time to really, um, well, I think one of the biggest things that's hardest about neurology is that, sometimes, sometimes the types of complaints, of issues that come to neurologists can be a little bit vague or very vague. So, like, for instance, if someone came to me complaining of blurred vision, or if someone referred someone to me for like blurred vision, that's kind of, in my mind, it's kind of a vague complaint. Well, what do you mean by that? Like, what? Um, and so it takes time to really drill down and figure out what's going on. And sometimes, it's almost impossible to really figure out, um, what exactly is meant by that. And I mean, that's part of medicine in general. Of any complaint, there can be ambiguity. Um, but that's sort of the nice thing about neurology and neuro-ophthalmology is, we depend on our exam and our clinical skills and our reliance on kind of testing to try to figure that out. Is it something vague, like blurred vision? Is it just like, you have some dry eye and you need to take artificial tears, or do you have optic neuritis and you need to be on steroids and you need to be seen by an MS person? That's like, I think what's really cool and powerful about neurology is that, we really, we use our kind of senses and our exam to help the patient figure out what to do next.
And what advice would you have for someone interested in neurology and neuro-ophthalmology?
Um, ooh, I would say try to get a broad experience. If you're able to shadow or, spend some time. Neurology it's a huge field right now. It's like really exploded a lot in the last, decade. The kind of this, I think there's like always this stereotype among like doctors and students that it's sort of like, diagnose and adios. Like, you're like this armchair doctor. You just sit there and, diagnose these weird, rare conditions and then send the patient out of the office. That's not the case at all anymore. We have so many effective, treatments and therapies, um, in every area of neurology, from dementia to migraine. I mean, so there's like, it's really burgeoning, and, there's a lot you can do within neurology. Um, and when I trained in it, I was mostly seeing patients with like strokes. Neurology training is still very inpatient focused. It's very focused on, acute neurological issues. But a lot of the neurology that's happening is outpatient. So, um, try to get as much of exposure as you can. And there are just some really interesting areas. I mean, within neurology, like sleep medicine is really cool. That was something I kind of spent some time doing. Movement disorders, um, MS, neuro-ophthalmology, migraine, headaches, and it's very subspecialized. So, like the really there are general neurologists who do like a little bit of everything. But nowadays, I think a lot of people are very subspecialized. So you can really see it, you can see like going from one clinic to another, they're totally different from one another. And the drugs are so somewhat complicated at times to understand. Um, so it requires sort of some subspecialization. But try to get a broad exposure. Go to like case conferences and morning report. Those are where the really kind of fun, interesting cases happen, where you see neurologists sort of thinking. You can see how neurologists kind of think through cases, how they're thinking about patients. Um, if you're able to go to like AAN or those conferences, those are a lot of fun. You'll meet like tons of people, and there's a lot of different talks for a lot of different ranges of folks. So it's really a fun field, and if you're interested in it, I would encourage you to really explore it.
Okay, and our last question that we kind of like to ask everyone is what is your favorite part of the brain or central nervous system and why?
I guess I'm kind of biased, and I mean, the optic nerve probably would be my. Um, it's just super cool, and it's got it's like a million neurons, but it's so subspecialized, and it does a lot of different. It really processes an amazing amount of information. I mean, like basically, someone there's this some few people have said throughout my training that like 60 to 80% of your brain is just dealing with vision. That all starts at the optic nerve. That all is handled by the optic nerve. So it's just a very powerful part of your brain. It is the brain, and and it's kind of what I look at every day. So it's what I like. um, yeah, I don't. It's not the best reason, but
No, fair enough. Well, thank you so much for your time, Dr. Schwartz. We appreciate it.
no problem. Thanks so much.